So septic shock, when we think of this, we think of inflammation from the body due to infection in the bloodstream. So this is a multi-organ failure kind of shock, and to really be septic shock, the patient has to have persistent hypotension, and there's different stages of severity, which I'll talk about. And since you can't really see it on the video, the first stage is systemic inflammatory response syndrome, which we were talking about in distributive shock. The patient must present two of these symptoms, which is a temperature higher than 100.4 or a temperature lower than 96.8, a respiratory rate greater than 20, a heart rate greater than 90, white blood cell count greater than 12,000 or less than 4,000, and a PCO2 less than 32 millimeters of mercury, which they make this the mild stage because we could have two of these symptoms exercising. I mean, our heart rate could be greater than 90, and our respiratory rate or temperature could be greater than both of these numbers. So the next stage is called just sepsis, and it's two of the symptoms of the systemic inflammatory response syndrome and a confirmed or suspected infection. The next stage is severe sepsis, which is sepsis plus signs of organ damage and hypotension starts to become present, so systolic pressure less than 90. And the next stage is the severe stage, which is septic shock. So this is where there's persistent hypotension. So no matter what you do, no matter how much fluid you give, the patient still just has persistent hypotension. And this is where they start showing signs of multi-organ failure from the low blood perfusion and oxygenation to those organs. So right here I have different arteries in the middle. This is a normal artery. Over here is a constricted artery, and this is dilated. So this is what the arteries will look like in septic shock. So white blood cells usually fight outside of the artery, but during this shock, the vessel becomes what we call is leakiness, and becomes more permeable to the white blood cells, so they can go inside the vessel and fight the infection. So with the vessel being more permeable and have leakiness to it, fluid forms around the vessel and really makes it hard for oxygen to participate in gas exchange. So some patient assessment findings: fever, chills, confusion, difficulty breathing. This chest x-ray right here is a patient that has developed ARDS, and difficulty breathing could be a symptom from that, because when you have ARDS, it causes damage to your alveolar tissue in your lungs, and this will increase your stay in the intensive care unit if you have ARDS from septic shock. So it's really important to identify these symptoms and signs as early as possible, especially in areas where you can drain the infection and take care of it in the early stages, such as the abdominal cavity. So there's different symptoms a patient will have from where the infection could be, and so a chest and pulmonary infection, cough, chest pain, shortness of breath. Cardiac infections, they might have a new murmur that you can hear, especially in patients with a history of injection and IV drug use. Abdominal and GI infections, abdominal pain, diarrhea, and abdominal distension might be present. So hemodynamic monitoring, the cardiac output can be normal or increased. Pulmonary capillary wedge pressure is normal or decreased. So this is completely different from cardiogenic shock. So the heart can be having a normal output or even increased, and the body still be in shock from those dilated vessels. And vasopressors will be given to the patient to maintain a mean arterial pressure of greater than 65 millimeters of mercury. It's very important to monitor the right ventricular volume overload when giving the patient large amounts of fluid. If you do not monitor this, and you're just giving them a large amount of fluid, they could develop cor pulmonale. And some pharmacologic options. So norepinephrine and dopamine are your vasopressors, which will constrict the blood vessels and increase blood pressure. And epinephrine is kind of your backup if the norepinephrine and dopamine aren't working. You'll go to epinephrine for a vasopressor too. And phenylphrin can be given to a patient that has severe tachycardia, but you do have to be careful with this as it does cause myocardial depression and decreases their heart rate. And normal saline can be given to increase their intravascular volume. And oxygen is highly recommended for patients showing respiratory distress and if their oxygen saturation is decreasing. For mechanical ventilation, for septic shock, you do want to use that lung protective strategy for the patients that do have ARDS. So we're going to use that 4 to 6 milliliters per kilogram of ideal body weight range. Use PEEP as it recruits the alveolar unit, so the alveolar that's being damaged from the ARDS, that PEEP can be very helpful in increasing oxygenation. So always monitor hemodynamics when you're making changes to PEEP. This is very important, not to just make changes and walk away. So the goals from the mechanical ventilation that we're going to use for the patients, we want to improve gas exchange. And most importantly, we want to avoid further lung injury and really try to help those lungs heal and decrease the stay in intensive care unit.